My name is Haven. I am a speech language pathologist at Rady Children's Hospital here in San Diego. I specialize in feeding and swallowing disorders. It's sort of a subspecialty of speech therapists. It takes a village. Anyways, as I was listening, I was thinking, wow, I have so much information I would love to share. You obviously have a lot of questions. No, it's an orange one. And we have limited time, and just know that if I don't get to your question today, I will be passing out my cards and you can email me or call me. I'm happy. Thank you. That's it. And so it's really nice that we heard about the medical and also some of the nutritional aspects of feeding and swallowing problems, because where I come in is after we've managed the medical and the nutritional, we've got those stabilized. And then what do we do? Because we can't just live with a G-tube the rest of our lives. Most of us have a goal to get back to being an oral feeder after that. And so what do we do? And we have some programs at Rady Children's I'm going to talk about, but the general philosophy towards feeding therapy is something you could find at many different institutions, not just at our hospital. And so before we start, I'll just tell you I don't really have anything to disclose, except I have a deep passion for both children and anything related to eating. So I have the perfect job. I love kids and I love to eat. So sometimes when we're doing feeding therapy and we have the food out and we're supposed to be working children through our little hierarchy, and I run out of food to demonstrate to the children because I've eaten it all too quickly. So anyways, all right. All right, so let's see what's next. So like I said at the beginning, we have multiple components to our treatment programs. We have to address the medical and nutritional issues. If a child is a failure to thrive, we need to make sure we're meeting their nutritional needs for growth and development and to help them with their disease. Then once we've got those kind of under control, our multidisciplinary approach at Children's, we start looking at the last four areas: sensory, oral motor, behavior, and parent education. And what I mean, I'm just going to explain those. What I mean by sensory, let's see if that's on the next slide. Not yet. Okay. So sensory is the way we perceive things. So you have 5 senses. Does anyone want to name them? Sight, hearing, taste, touch, and smell. Okay, so eating by mouth involves all 5 of those. So if you have a problem or dysfunction in any of your 5 senses, it's going to impact eating. And how does this happen in our children? Well, let me just explain to you what happens when we eat normally. First of all, we see the food being prepared. We smell it being cooked. Think about turkey on Thanksgiving. Okay, if you smell that turkey cooking, you're already hungry and ready to eat. You hear the sounds of what's going on in the kitchen, of the table being set, of the silverware being rattled. When the food comes to you, you touch it. Children eat with their hands, and that is good. That helps them prepare. If they touch it, they feel it. They touch it and feel it inside their mouths, and finally they taste it, and they smell it even more strongly once it's in their mouth. So if you have an interruption or a change in any of those areas, then that's going to impact their willingness, maybe is a good word, to eat. And so examples of things we do to disrupt the sensory system in our children come from really good places, like treating their medical condition. But when we have nasal cannula, that's rubbing on the face and the lip all the time, and then you have to adjust that. You might have tape. You might have an NG tube also, that's got tape. There may be interventions that happen inside the mouth. Some facilities do oral gavage feedings with tubes in the mouth, and sometimes we have to do oral care, and our children don't want it, and it's imposed upon them by all of us who have really important reasons why we are imposing these things on our children. But they learn that things that go on in my face and my mouth are unpleasant. So guess what happens when you come at them with that spoon or the nipple from the bottle when you're trying to do an oral feeding, or even the breast for that matter? It can be something that's scary and unpleasant and beyond their control. So that's where the root of the sensory or oral aversion can come from. Next step, oral motor. So what I mean by that is movement of the mouth and control of the mouth and also the throat where we have the swallow. If you have a problem there for whatever reason, you cannot swallow properly or you cannot chew properly, that's going to interrupt feeding. And so examples of this would be what Dr. Vesey already talked about with aspiration. If you are, every time you swallow liquid, some of it's going into your lungs, even if you don't cough and sputter and eyes turn red, sorry, face turns blue. On some level, your body is sensing that, and infants very, very quickly learn to turn away from a feed if they're aspirating. And that may be one of the first signs that we have that they are aspirating, even though we can't prove it. So you have these problems in one or both of these areas of sensory and motor, and that can lead to learned behavior. So like I said, the infant, the newborn, very young, will quickly learn to turn away when oral feedings are offered if there's something going wrong. And unfortunately, children are very smart and very impressionable, and once they learn something, even after we correct the situation that's led to that learned behavior, they will persist. So an example would be some of our children who have reflux. They eat, the food goes in, then the food's refluxed up to some level. They learn to associate maybe pain, burning sensation from reflux of acidic stomach contents whenever they eat. Or it may come up even higher, and they may taste and smell. I'm sorry if that's graphic right after lunch, but we all burp after we eat sometimes, and it's a reminder of what we just ate. So you're associating the smell and taste of food with that pain and burning. And after we treat the reflux or the child grows out of it and it's no longer a problem, we can do all the tests and prove it's gone, the child still remembers. I mean, how many of you have ever gotten food poisoning and you become very, very ill? Do you ever want to go back and eat at that Chinese restaurant again? No offense, I love Chinese food. But it's very, very, the association between pain and discomfort and illness and the things that immediately precede that are very strong and very difficult to relearn. And that leads to the last category, which is parent education. Our programs are, we could not do what we do without our parents. Not just my parents, but the parents of our patients. So we involve our parents in every session of therapy. And when I say therapy, what am I talking about? We have single discipline therapies. We also have multiple discipline therapies at our hospital. And you might see therapy with an occupational therapist, a dietitian in our outpatient nutrition clinic. You might see a speech language pathologist, gastroenterologist, otolaryngologist, just depending on the unique characteristics of your child's case. And sometimes you may see a doctor for one visit and he'll prescribe medical therapy. Sometimes you may come once or twice a week to see the feeding therapist, who could be from OT or speech pathology. It depends on your child's specific needs. And at our hospital, we have a lot of multiple discipline programs, including an evaluation and some group programs. And as we heard before, bringing your children into group programs might not always work because of the germs. Not just in the group with the other children, but in the waiting room in our clinic. If you have 5 children coming to a group and then 10 other children in the waiting room going to various other appointments, there's a lot of germs flying around. So I'm going to just briefly talk about the first item, or the first 2 items on this slide, and that is the transdisciplinary approach is something that's gaining more and more ground in our field, which isn't really recognized as a field. Feeding therapy is not technically a field, and if you ask your insurance company to pay for feeding therapy, they're going to say, what is that? But what we do in our teams is we are all very closely working together and cross-training. So you might see the occupational therapist, but she may be able to address some of the swallowing problems that traditionally only speech-language pathologists would address. So there's a lot of cross-training going on. If you go to outpatient nutrition and see one of our fantastic dietitians. They can teach you a lot about sensory problems that traditionally you may have only gotten by going to an occupational therapist. And I think that's more and more important in the world that we live in, where funding is more and more short. So if you can see one person who can cover a lot of bases for you and do a really good job, that saves you from going to 5 appointments and paying for 5 appointments. And that's where we get the feeding therapist. And so someone who works with you on feeding doesn't have to come from one particular discipline. And I want to stress that, because depending on what part of the world you go to, you may be told, well, you can't get feeding therapy from that discipline. You have to go to this discipline. And the bottom line is the person who helps your child is the person that you should be seeing. Okay. This is just a picture of one of our feeding therapists who's engaged in negotiations with this little girl who's saying, I'm not going to eat this one, but I'll eat that one. That's in one of our groups. And I talked a lot about what we do in our groups, and that is me with some of our kids. We do sensory preparation because, remember, I talked we have sensory dysfunction in some of our kids, and so we're actually playing with shaving cream on the mirror. So you're touching it and you're smelling it, you're seeing it, and that's as a preparation for one of our actual therapeutic meals. And we do oral motor practice, so you can see the teeth and the biting. That's what your muscles in your mouth do. They bite, they chew. But interestingly enough, do you see both of these children have the fingers kind of out, like, I'm touching this, but I'm not really happy about it. I don't want to get dirty. Your kids who don't like to get dirty, who are always asking to wipe my mouth, wipe my hands, that's a sign of a sensory limitation. So I would encourage you to say, first of all, it's okay to be dirty. Dirt don't hurt. And second of all, if they really insist, say, here's your napkin, do it yourself. Anyway, obviously within reason. So we also take a developmental approach to our therapy. So we have certain programs for younger children who aren't ready to separate from their caregivers, where we work on their unique developmental needs as precursors to feeding. We spend time on tummies, because if you have a G-tube, your mom or dad is probably really protective of that area and never puts you on your belly because you probably don't like it. And so we work on that because that's important for general development. We help parents with teething, and some kids need to be weaned from the bottle. You know, if your 4-year-old is still taking bottles, we have to work on that. And the bottom point, very important for our little ones, self-imposed. So we have children who come to therapy who are like this. They're expecting everything to be imposed upon them by someone else. What do babies do? Well, I don't know. I mean, I'm assuming most of you in this room have had babies, and at some point they become very independent, and they don't want you to do it to them. They want to do it to themselves, and they will accept things into their mouth that they will put in that they would never accept if it came from you. Yes, so we work a lot on helping parents to understand that if your baby takes one taste during our therapeutic session that's self-imposed by themselves, that's probably worth 20 tastes that you forced on them. Our preschoolers, obviously this looks like a little preschool group. We sing songs and we read stories and we play with food. Sometimes parents say, what are you doing? You're not feeding my child, you're playing with food. But remember that sensory piece, and also the independence piece. We're teaching children to gradually desensitize them to sensations that may have been learned in an unpleasant manner initially. And for school-age children, we have yet another kind of program where we focus a lot on school-type activities, where we teach them things about digestion and nutrition, and we also eat. This is one of our parent groups. You can see the observation windows. The kids are in therapy in the other rooms. The parents are learning. They're with the psychologist and dietitian. They're learning about nutrition, about behavior management. One of my favorite lectures that our psychologists frequently give is called The Feelings You Bring to the Table. It's about parents and how we feel about eating. You would be surprised how your own attitudes affect how your child eats. Mm-hmm. Yes. We use social stories. That is the outcome. That's my niece, I have to say. Disclosure. And I have some references. So that is just really the tip of the iceberg in terms of what we do. So I'm going to go over there and sit down, and then we're going to answer questions, I believe. And I don't know how much time we have, but if you don't get your question answered, I'm happy to email or talk on the phone.